Screen visible?
Yes, it is.
Yes. Okay. I know it's been a very long session, so I'll try to cover it quickly as possible. So the first question. Is the slide visible? You can put in the answers. Okay, so for lack of time, I think we'll quickly, as soon as I see the correct answers, I'll go ahead with the answers. So I'm getting in a lot of answers. Yeah. So as you can see, there is dissociation of both the QRS complex and the P wave. So this is a diagnosis of a complete ROLA is the implicated antibodies. What are the other names for ROLA? SSA and SSB. Correct.
Hello.
Yeah, hello. Am I audible?
Yes, sir.
Okay. So the last question was management. So what do we do? What is the management for baby with congenital heart block? Okay, so we are getting answers, pacemaker. So there are a lot of differences in, so not all congenital heart blocks are put on pacemaker. There are certain babies who have who has a slight improvement in their heart rates after delivery. So such babies can even escape without a heart pacemaker. There are certain drugs that are used that is ideally given a trial, but definitely pacemaker is the final solution. Okay, the second question. So read the question carefully. There are three parts to it. So the first question, what are the three typical findings in this MCO? So what are the three things that you see in this MCO? Okay, one answer we have got. So we are not asked the diagnosis, is this the findings that is, yeah. The slide is visible, right? Someone has written that the question is not visible. Okay, I'll go to the answers. I've got only one correct answer. So there is three parts to the finding. One is the proximal urethral dilatation. You can see below. The bladder is the typical classical finding, that is the trabeculated bladder, and the high-grade vesicourethral reflex. So the primary treatment is fulgration and vesicostomy. And since there is VUR in this baby, we are also sending the baby on uroprophylaxis. Okay. What is this? What is this equipment? What is the different settings that we use for babies? One is the term baby and one is for the 35-week-old. Okay, everyone has got the device correct. This is the oxygen blender. Air oxygen blender. Okay, so we have got all the right answers. So for a 35-weeker, we keep somewhere between 21 and 30. Some starts with 30, some start from 21 and go up to 30. In term babies, it is room air. Question number 4. Okay, the diagnosis on the neurosonogram 1 is grade 3 IVH. What is the index being calculated in the second figure, figure B? Okay, figure B is the ventricular index. The definition of ventricular index is the distance from the falx to the lateral wall of the ventricle. Question number 5. You can put in your answers. First question is to calculate the oxygen index. Then, what are the any two echocardio finding of a baby with PPHN? Okay, I think we have got most of the answers correct. 28 is the OI in this baby. Any of these, that is, you have a TR jet velocity, which is anywhere more than 15 to 30, you can consider as moderate to severe. A D-shaped or a crescent-shaped RV dilated, RV hypertrophy, intraventricular motion artifacts, PAT by RVT ratio less than 0.2, or even a severe right to left shunting at the PF or PDA. Improvement is something that when you start a baby with an OI of 20, and if the INO is started at 20 parts per million, you would see a change in the PaO2 by FiO2 by at least 20 millimeters over a 20-minute period is known as the 20-20 rule. And that shows that the baby has improved or has responded to INO. I think you can just mention the other two indices. The first indices we have already discussed. The second diagram. So the answer here is that it is the thalamo-occipital distance. Okay. Question number 7. What is the diagnosis? What is the key prognostic criteria while describing or expectations from the parents, and what is the immediate management? Okay, diagnosis is correct, Erb's palsy. So this is a left Erb's palsy. So how do you prognosticate? Okay, and we're getting answers in parts. Okay. So this is the left brachial plexus injury, or also known as the Erb's palsy. The finger grasp and the return of biceps function by at least 3 months is an indicator of good recovery. So completely paretic limb, completely floppy hand with a Horner syndrome and diaphragmatic palsy has poor prognosis. Do's are that you should always rule out a birth trauma. That is, you are to rule out a humerus fracture or a clavicle fracture. You should support the limb adequately. No overt or excessive massage. No excessive physiotherapy for the first 2 weeks to prevent further neuronal injury. General range of motions can be helped with. Okay, in this question. So what are the ultrasound findings which show a poor outcome in UTD? Okay, the answer, I'll go into the answer. This is a severe dilatation of more than 15 millimeters, bilateral renal involvement, oligohydramnios, or any features of Porter sequence shows that the renal involvement is severe and has poor prognosis. Once the baby is delivered, if you have bilateral UTD, you have to make sure that a PUV is ruled out, especially in a male baby, and a follow-up at 6 weeks with an MCU. If it is PUJ obstruction, we need to make sure that a surgery is done. Question number 9. What is the diagnosis? Okay, so we have got to write the answers. The port wine stain. So the follow-up usually is that they are prone for severe neonatal seizures with polymedications. So a follow-up with neuroimaging and MRI or a CT, intraocular pressure monitoring and glaucoma is the neglected areas that we miss. So that also has to be a part of your neuro follow-up. Okay, it'll take some time in this case. So the chart that you have seen here is of a baby which has been screened by the DDST, that is the Denver Development Screening Tool, at a 9-month corrected age. Can someone tell what is the domains that is being checked and in which order? In this case, what is the test report that you will give to the family? And what advice would you give? I hope the slide is visible. So Pooja has come with the right sequence. That is, as per the chart itself, you draw a line. The line is drawn at the age at which the baby has presented to the OPD. That is the corrected age. And after you draw, you evaluate to the beginning from top to bottom. So it is the personal social that is evaluated first, then the fine motor adaptive skills, language, and then finally the gross motor. There is also a column for reported, that is what the parents report to us. So that should be the first thing even before touching the baby. So reportable items and personal social are done first, then comes the fine motor, then language, and then finally the gross motor. Scoring, as you can see, you give a pass. A pass is when the baby is able to do at that. So if you see the slide, so if a baby passes, it is always necessary to do the next upwards to see till where the baby. So if you have marked 3 fails, that is when you stopped assessing at that domain. So since here, if you see the fine motor in this baby, the baby actually has passed at 9 months. He has passed this. So the next one, you evaluate 3. That is after a pass, you evaluate the next 3 items. And if it is consecutively showing a fail, then you stopped assessing that area. So in this, you can see the language, the baby has failed on the line of the 75th centile. So the baby has not passed. So this is caution in language. Again, similarly in the gross motor, again, the baby has not passed at the 50th centile. That is pull to sit. So, sorry, this is pull to stand. And so the baby has a report here would be that the gross motor and language is suspect. Fine motor and personal social skills is normal. You will do a re-evaluation after 1 month. And in the interim period, you will give advice on stimulation on the specific. If it is coming again suspect in the same areas, we will do a detailed diagnostic test like a BSID, that is Bailey scale. Question number 11. So Pooja has got those answers correct. Good. Yeah. So question number 11. So what is the underlying abnormality? So this is a 40-week-old male neonate with a respiratory distress and cyanosis soon after birth. Cyanosis and distress resolved after intervention, as depicted here. Correct. So it is a bilateral choanal atresia. What is this called? This device? This is a modified device. This is an adapted device. Can someone name the apparatus? Okay. So this is a diagnosis of bilateral choanal atresia. What you see here is the McGowan nipple. So this is a nipple with a very large hole at the teeth, and it can be secured with tie. This allows, it's almost acts like a oropharyngeal airway. So the final confirmatory or diagnostic procedure would be to do an endoscope and do a criblet. Okay, the second last question. The picture here depicts a curve. Can someone name the curve? And the answer is already there. Okay. What is the sensitivity and specificity at the specified point? So the x-axis, the x-axis depicts the sensitivity and the y-axis is the 1 minus specificity or the 100 minus specificity. So at this point, this test has a sensitivity of 80% and a specificity of 100 minus 10, that is 90%. And the last question, you can see this is a medical package of a drug that is used quite rarely in the NICU. What is the indication? Okay, we need complete answers. ROP is, what type of ROP will you give this drug? How is this drug given? What is the dose and mechanism of action? Again, ROP plus an aggressive ROP. Again, these are all part answers. Stage 4, no. Stage 4, we have already lost the battle. Okay, the indication is when you have an ROP that requires treatment, you have an option of giving laser and you have the option of giving anti-VEGF. So anti-VEGF are two, bevacizumab and ranibizumab. Intravitreal injections 0.1 to 0.2 mg per eye is given. Zone 1 ROP, preferably the ophthalmologist try to prefer giving anti-VEGF because there is a more higher risk of the blindness because of photocoagulation using a laser. So when the zone 1 with any plus disease or zone 1 with stage 3 and any aggressive ROP, you would be trying to do ROP treatment with ranibizumab or in VEGF, anti-VEGF drugs like ranibizumab or bevacizumab. Okay, I think most of you have got the answers correct.
Thank you, Ajay.
Just a word of advice, try to keep the answers very specific.